Welcome back to the deep dive. Today we're going to talk about something you're using right now, or at least something you're listening to me use. Your voice.
It's one of those things, isn't it? You don't really think about the mechanics of your car until it breaks down.
Right.
You don't think about your voice until you wake up one morning and it's gone.
Exactly. And usually that narrative is pretty simple. I went to a concert, I screamed too loud, or maybe I caught a cold. Sure. I drink some tea with honey, I shut up for 2 days, not bad. But what happens when that hoarseness just doesn't go away? What if laryngitis turns into a 2-month saga?
And that's where the story really shifts from a minor annoyance to a full-on medical investigation. We're looking at the voice today not just as a way to communicate, but as a vital sign.
A diagnostic map.
Yes, a map that can tell us about infections, structural failures, or even, life-threatening conditions.
So to ground this, we're going to follow a specific case. Consider this our true detective moment, if you will. We have an elderly male patient. He walks into a clinic, and he sounds rough. He tells the doctor his voice has been changed for 2 months.
And that is our first major clue. Immediate red flag. Acute laryngitis, the kind you get from a virus that lasts a week, maybe 2 at most.
2 months is not that.
2 months is chronic.
Yeah.
The body is telling us something has fundamentally changed, structurally.
And it's not just the voice. He's been struggling to breathe for about 20 days. He has pain when he speaks, and he's coughing up sputum. Initially it was blood tinged, but now it's more mucousy.
So we have a timeline. Long-term hoarseness, followed by breathlessness, followed by blood. That progression is ominous. It suggests something is growing, taking up space, and maybe eroding tissue.
We also have his rap sheet, or rather his history. He's a smoker, he's a heavy drinker, and here is the curveball. He was treated for pulmonary tuberculosis TB 10 years ago.
So the board is set. We have the usual suspects of tobacco and alcohol, which they point toward cancer.
Right.
But we have this ghost of a past infection with TB. Our job is to decode the sounds coming out of his mouth to figure out which one it is.
Okay, so let's start with that decoding process. I used to think losing your voice was just a binary thing. You have a voice or you don't. But digging into this, I realized doctors have a whole vocabulary for how you lose your voice.
Absolutely. The quality of the sound tells you exactly which part of the instrument is broken.
Take husky, for example. If someone tells me I have a husky voice, I'm taking that as a compliment. It sounds, sultry. Jazz singer vibes.
In the real world, maybe? In the clinic? No. A husky voice is actually a very specific kind of failure. It usually points to a paralysis of the superior laryngeal nerve.
Okay, unpack that for me.
Yeah.
Why does a nerve issue sound husky?
So that nerve controls the cricothyroid muscle. And you can think of that muscle as the tuning peg on a guitar. It's what stretches the vocal cord to create tension. If that muscle is paralyzed, the cord goes slack. It can't tighten up. So you get this breathy, air-leaking sound. That's husky.
Got it. Slack guitar string. So how's that different from being hoarse?
Hoarseness is about the cord itself. For a clear voice, the vocal cord needs to vibrate in a smooth, perfect wave. If you have a physical bump, like a nodule, a polyp, or a tumor disrupting that wave, the sound becomes rough and gritty. That's hoarseness.
So husky is the tension, hoarse is the surface.
Precisely.
Then we have my absolute favorite medical term, the hot potato voice.
It's a vivid, isn't it?
It's perfect. It sounds exactly like it is, muffled, thick, like you're trying to talk with a mouthful of steaming mashed potato. But this one is dangerous.
Right, extremely. If our patient had a hot potato voice, I'd be worried about his airway immediately. It means the problem isn't even the vocal cords, it's the supraglottis, the area right above the cords, or the base of the tongue.
Oh, it's swelling.
Massive swelling. The tissue there is so boggy that it changes the whole resonance chamber. It muffles the sound before it even properly gets out.
Okay, so for our patient, he's been hoarse for 2 months. If he sounded husky, we look for nerve damage. Hot potato, we look for major swelling. But since he's just rough, we're looking at the cords themselves.
Most likely, yeah. But there's another layer to the detective work. Time of day. This is what we call diurnal variation.
This part blew my mind. The idea that when you lose your voice can tell you why you lost it.
Think about it. If a patient says, "Doc, I wake up with no voice, but by lunch I'm fine," what does that suggest to you?
My gut says inflammation, like things stiffen up overnight.
You're very close. It's usually chronic laryngitis. Overnight, while you're lying flat, mucus pools in the throat, the cords get bathed in this inflammatory soup. You wake up, cough it out, move around, the swelling goes down, and the voice comes back.
Okay, but flip it. What if our guy wakes up sounding like an opera singer, but by 6 p.m. he can barely whisper?
That's the scary pattern. That suggests vocal fatigue. It could mean a vocal cord palsy where the muscle is weak and just gives up after a few hours of work. Or worse,
Malignancy.
Malignancy.
How does cancer create fatigue?
Well, the cancer itself doesn't get tired, but it makes everything around it work harder to compensate. The structural integrity is just compromised, so as the day goes on, the system fails.
There's also mention of Reinke's edema, which is a fluid swelling often linked to smoking. That can actually get better during the day.
Sometimes, yes. Reinke's edema is like having little water balloons on your vocal cords. When you use them, the fluid can kind of redistribute, which temporarily improves the sound.
So for our patient, he's a smoker.
Yeah.
If he says, I sound better after my morning coffee, we might hope for Reinke's edema. If he says, I sound worse after dinner, we're worrying.
We're worrying about cancer or paralysis. Yeah. Exactly. And remember, he's not just hoarse. He's having trouble breathing.
Right, the breathlessness. And here we have to distinguish between 2 sounds that I honestly thought were synonyms, stridor and stertor.
They are definitely not synonyms, and knowing the difference can quite literally save life. Stutter is basically a snore. It's a low-pitched, snuffly sound. It means the blockage is high up nose, throat, soft palate. It's noisy for sure, but air is getting through.
So stridor is a heavy snore. What is stridor?
Stridor is a warning siren. It's high-pitched, harsh, sometimes almost musical. It implies the airway is being squeezed shut. Imagine breathing through a wide straw, and then imagine breathing through a straw that someone has pinched in the middle.
Oh, yeah.
That turbulent hissing noise. That is stridor.
And the timing matters here too, doesn't it?
Yeah.
Whether it happens when you breathe in or breathe out.
Physics comes into play. If you hear the noise when the patient breathes in, that's inspiratory stridor, the blockage is usually above the vocal cords.
Why is that?
It's negative pressure. When you suck air in, the flexible tissues above the cords get sucked inward. If there's a mass there, the suction pulls it right into the airway, causing that sound.
That makes perfect sense, like sucking a curtain into an open window.
That's a perfect analogy. Now, if the noise is when they breathe out expiratory stridor, the problem is lower, in the trachea or bronchi. Because when you blow air out, pressure builds up in the chest and compresses that lower airway.
And if it's both, noisy in, noisy out.
That's biphasic, and that means the bottleneck is right in the middle, the glottis, so the cords themselves, or the subglottis. It's so narrow that air struggles both ways.
Our patient has been breathless for 20 days. If he has biphasic stridor, that narrows our search radius to the vocal cords immediately.
And we categorize that breathlessness by grades. Grade 3 is, I get winded running for the bus. Grade 4 is, I am winded sitting right here in this chair. If our patient is grade 4, we aren't chatting anymore. We are rushing him to surgery to secure an airway.
Okay, now let's bring in the ghost of the past. This patient had TB 10 years ago. I feel like in modern medicine, we often dismiss TB as just case closed. But you're saying it can come back to haunt the voice specifically.
Laryngeal tuberculosis is incredibly painful and deceptive, and it has a very specific way of attacking the throat that actually relates to Gravity.
Gravity, how?
Okay, think about the mechanism. If you have active TB in your lungs, you are coughing up infectious sputum, millions of bacteria. When do people usually cough the most?
At night or when they lie down to sleep.
Exactly. So you lie flat on your back. That sputum doesn't just disappear, it pools. And because of the anatomy, it creates a little puddle in the back of the throat, specifically the posterior commissure. Think of it as the back shelf of the voice box where the vocal cords attach.
So it's essentially a septic tank just sitting on the back of your vocal cords all night.
That's visceral, but accurate, yes. That stasis, that standing fluid, allows the bacteria to invade the tissue right there. And that's why TB almost always attacks the posterior part of the larynx first.
That is fascinating. And visually, it looks distinct from cancer, right? It has a certain look.
It can. TB ulcers are often described as mouse-nibbled.
Mouse-nibbled. That is a very gross image.
It looks ragged, irregular, like something has been chewing on the edges of the vocal cord. And sometimes the infection spreads to the epiglottis, the flap that covers your windpipe, and causes such massive swelling it looks like a turban. A turban epiglottis.
But the big differentiator here is pain.
Yes, early stage throat cancer is often painless. That's why it's so dangerous. People just ignore it. But TB of the larynx, it hurts. Specifically, you get otomenophagia, painful swallowing. Our patient has pain. That keeps TB on the suspect list.
Okay, so TB is a strong contender, but we have to talk about the elephant in the room, or rather the two elephants, tobacco and alcohol. This patient does both. And I was shocked to learn how these two substances actually work together. It's not just 1 + 1 = 2. It's like 1 + 1 = 10.
It is a synergistic nightmare. We all know tobacco is bad. It has benzopyrenes, tar, all these carcinogens that, smash up your DNA. But alcohol is the accomplice that holds the door open for them.
How does that work?
Think of the lining of your throat, the mucosa, as a protective wall. It's designed to keep bad stuff out. Well, alcohol is a solvent. It physically dissolves the lipid layers of that lining. It breaks down the wall.
So the alcohol strips away the armor
And allows the carcinogens from the tobacco to soak directly into the deeper tissues. The alcohol acts as a vehicle, driving the poison deeper than it could ever go on its own.
That is terrifying. So if you smoke while you drink, you are essentially just marinating your cells in toxins.
You really are. And it gets deeper. Alcohol metabolizes into something called acetaldehyde. Acetaldehyde interferes with DNA repair. So the tobacco damages the DNA, and the alcohol prevents the body from fixing it. It's a perfect storm for cancer.
And I noticed the notes mentioned that the type of alcohol matters. Are you a wine person or a whiskey person?
It's about the congeners, the impurities and other compounds in the drink. Dark liquors like whiskey and rum have more of these volatile organic compounds than clear liquors like vodka.
Beer?
Beer has nitrosodimethylamine, wine has tannins. They all add to the carcinogenic load. But the heavy spirits, combined with chain smoking, are the most potent fuel for laryngeal cancer.
And doctors actually do the math on this, right? Pack years?
We do. It helps us quantify risk. It's just packs per day multiplied by years smoked. So our patient, if he smoked a pack a day for 40 years, that's 40 pack years. The risk of cancer correlates almost perfectly with that number.
So we have a patient who has been marinating his vocal cords in solvent smoke, possibly for decades, but he also has that history of TB. How do we actually look inside to tell the difference?
We have to do a laryngoscopy. Now today we have amazing fiber optic cameras that go up the nose. But the classic way, the way every ENT learns, is the IDL, indirect laryngoscopy.
It sounds so archaic to me. It's basically a dentist's mirror on a long stick.
It's low tech, but it is high skill. You have to place this mirror against the soft palate, angled just right to reflect the light down the throat and see the cords.
But mirrors fog up, especially inside a warm, wet mouth.
They do. So you have to defog it. You can heat it with a flame, dip it in hot water. But the classic trick, the one you'll see old school doctors do, is to rub the mirror against the inside of the patient's cheek.
Wait, really? You just wipe it on the cheek?
Saliva is actually an excellent surfactant. It breaks the surface tension and keeps the mirror clear.
That is surprisingly practical. So the doctor's in there with the mirror, they pull the patient's tongue, which sounds uncomfortable, and say AAA. Why AAA and not like E?
AAA lifts the uvula up and back, getting it out of your line of sight. E is useful too, but that's to see the cords move. To get the view, you need AAA.
But here's the catch. The mirror doesn't show everything.
No, it has what we call fallacies. First, everything is reversed. Left is right, front is back. Second, you have no depth perception because you're looking with one eye. But the biggest danger is the hidden areas.
The blind spots.
Exactly. There are these little nooks and crannies like the ventricles, which are pockets between the cords or the subglottis, the area underneath where the mirror just can't see. You could have a significant cancer growing in the ventricle and the mirror exam looks totally normal.
Which is why the physical exam of the neck is so crucial. And this is where we get to the click.
Laryngeal crepitus. This is a feeling every doctor knows.
Describe it for me. What should it feel like?
You grab the voice box, the larynx, from the outside of the neck. You gently rock it side to side against the spine. Normally, cartilage rubbing against bone feels like, well, think of cracking your knuckles. You feel a distinct, smooth pop or click. That is healthy.
You want the knuckle crack.
You absolutely want the crack.
And if you don't feel it?
That is called Bocas sign. If you rock the larynx and it feels mushy or silent, it means something is in the way.
Something of the tumor?
Yes. A tumor in the postcricoid area acts like a shock absorber, a cushion. It lifts the larynx off the spine. So if you lose the click, you have likely found a cancer.
God, that's chilling. The silence is the warning.
It is.
Before we wrap this up, there's one more weird detail. Let's say our patient does have cancer. The treatment plan starts at the dentist.
It sounds like a bureaucracy error, doesn't it? But it's vital. If this man needs radiation therapy to the neck, the radiation will damage the blood vessels in his jawbone.
Okay.
Now imagine he has a rotten tooth, an infection. Normally the body fights that off, but in a radiated jaw, the bone can't heal. The infection can spread to the bone itself, causing osteoretic necrosis.
Which translates to?
Bone death. The jawbone literally dies and can fracture or rot away. It is agonizing and disfiguring. So before a single beam of radiation is fired, every bad tooth must be pulled or fixed.
It's incredibly high stakes.
It's incredibly high.
So let's solve the mystery. Our patient, 2 months hoarse, breathless, pain, history of TB, smoker and drinker.
The symptoms pull us in two directions. The pain and the history scream TB. The 2 months of hoarseness and the blood scream cancer. The mouse-nibbled look would confirm TB. A cauliflower mass would confirm cancer.
And because of that synergy of alcohol and tobacco, cancer is statistically more likely.
It is. But because he has pain, that otomenophagia, we can't rule out TB until we get a biopsy. In fact, it's possible it could be both. Old scarred lungs from TB are actually a risk factor for developing lung cancer later.
It's a complex web.
Yeah.
But I think the biggest takeaway for me is just how physical the voice is.
Mm-hmm.
We think of it as this abstract thing, oh, I lost my voice. But it's mechanics, it's fluid dynamics, it's geometry.
It is, and it's a warning system. If you are listening to this and you've been hoarse for more than 3 weeks, go get checked.
And don't just settle for, oh, it's probably nothing.
Right. Remember the hidden areas. Remember that the mirror can lie. If something feels wrong, if you have pain, if you have that referred ear pain we didn't even touch on, you have to push for the answer.
Because sometimes the most important sign is the one you can't see. It's the click you can't feel, or the hot potato sound that gives it all away. We'll leave it there. Hopefully you'll never need to know the difference between stridor and stertor, but now you do. Thanks for diving in with us.
Take care of your voice.
See you next time.